كيف اقرا السؤال؟
ولا هذا بعد
هذا المايك فقط يلزم.
اذا
ما ياثرون على
لا
بعض.
تقرا
والميكروفون
تمران
كذا نفتح بالاخضر.
تمران سؤال بسيط. الحين لازم اقرا وقدامي.
نعم كيف الحال؟
عبد الله يو ار لايف ناو على اليوتيوب وكذلك الحضور 21.
ودين الستيج عشان يطلع صوت وكل شيء.
لازم. كيف اطلعها هذه؟ كيف اطلعها؟
تطلعين فوق.
كيف اطلعها؟ ما في درج. اشقح. ما لكم امل اطلع هذه. كيف حد دكتور احمد كيف فارق؟ شوف يا دكتور تمار ابى اجي هنا ماني بشاقحه.
اجيب لك كرسي دكتور. طيب خلاص تجين هنا نجاة.
او هنا ايه.
اهم شيء يكون
يلا ممتاز. سم لا بس بنروح. هذا شغال الحين. اي خلاص شغل. هذا انت ولا انا؟
لا تسكين من بعيد.
شكرا جزاك الله خير. السلام عليكم.
ثواني بس.
مساء الخير جميعا. ما في صوت.
يمكن خربانة معك بس.
السلام عليكم. الحين تمام؟ كيف يا دكتور؟
دقيقة بس.
ها سامعيني؟ كذا يمكن؟
لا شوي دقيقة.
أنا أسمع صداي.
لا دقيقة.
حياك الله بروك محمد.
ثواني بس دكتور خلينا نشوف. بالله نادر في البيني المايك حد شكله هذه ما هي شغالة. تسمع صوتنا في الزوم ولا لا؟ هي هجر القاعة نفسها يمكن. السماعة شكلها مش شوية شغالة.
أنا أسمع صداي. إيه أنا أسمع صداي. تسمعون الصوت واضح؟
طيب خلاص
واضح
متأكد.
الصوت صح؟ أنا أسمع صوتي.
الصوت واضح هنا؟
شكلكم بال.
لا ما هو واضح هنا. هو مشكلة قاعة. كلهم مشبيني بالله. إيه قاعة فيها مشكلة ما أدري إيش.
في عندنا أحد منهم من الأوديوفيجوال؟
إيه من شوي في البيني. الصوت عندكم واضح صح؟ إيه بس مشكلة عندنا في القاعة هجر. كاميرا مايك القاعة مش هي شغال غريب. إيه بس. شوي شغال غريبة. لا يا أخي قاعة ما يوصل الصوت. إيه جدا واضح. لا شغال. هاي. طيب هجرنا نصور.
لو رفعنا الصوت تسمعون ولا ننتظر يضبطون الميكروفونات؟ تسمعون ولا ما تسمعون؟
من نفس القاعة بس الصوت مو واضح.
ما هي مشكلة مايك السماعات اللي هناك مي بشغالة.
جرب هذا دكتور.
السلام عليكم. واضح الصوت الحين؟ أفضل؟ طيب مساء الخير جميعا وحياكم الله. هذه فرصة جميلة نحن نلتقي مرة ثانية وإن شاء الله إلى مزيد من الفعاليات الحضورية. So today إن شاء الله King Saud University Medical City will present. We thank.
القاعة بس ولا هم صوت واضح عندهم مشكلة القاعة.
في الزوم يسمعونا بس أنتم اللي ما تسمعون السماعات هذه ما تشتغل مضبوط.
إيمان بالله هون في البيني ما تشغلت ساعات هذه السماعات هذه.
بيرفعون صوتهم الشباب.
اسمع. إيه في البيني يمكن هذه.
يرفعون صوتهم الشباب.
لا.
طيب. So in the beginning we grateful and thankful for Dr. Tamran for organizing this club meeting and Dr. Dhafir for organizing the Zoom meeting. Today inshallah Dr. Ali Al-Hussein F3 and Dr. Abdulaziz Al-Damkh F2 will present بإذن الله interesting cases for you. تفضل دكتور تمام.
السلام عليكم ورحمة الله. Thank you for attending this club meeting and as you know that we alhamdulillah in the SASPGHAN group we did the hybrid IBD and international IBD And today also, this is the first attempt for us to do another hybrid meeting. We hope to enjoy it, inshallah. And for sure, the presenting hospital KSMC promising us to present interesting cases that will be enjoyable for all of us and good teaching points for us, inshallah. Now, Dr. Ali will present the first case, Medicine 101.
Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, it is a very pleasure to present in front of respectful teacher and colleague. Inshallah, we will start this case. My name is Ali Al-Hassan, King Khalid University Hospital, F3 Pediatric Gastroenterology Fellow. Bismillah ar-Rahman ar-Rahim. We start our case. The topic is Medicine 101. We have Tamim, who is 8 months old boy, who have been admitted under the neurosurgery team for ventricular peritoneal shunt insertion. The reason of consultation that they have observed whitish material coming from the abdomen while attempt to open the abdominal cavity. He is known case of congenital heart disease in form of ASD and mild pulmonary stenosis, pulmonary valve stenosis. He is not on medication. He is as well known case of undescended testis bilaterally. He is a case of craniosynostosis post-repair with hydrocephalus, for which he have been admitted in our hospital for insertion of VB shunt. He is as well known to have a dysmorphic feature starting from the age of 6 months, and that we will talk about. Yeah, this one. Next. Abdulaziz is next. Yeah, he's a product of normal spontaneous vaginal delivery with uneventful pregnancy. He was discharged with his mother in a good condition with a birth weight of 2.97 kg. ايش المشكلة؟
دكتور عبد العزيز شو يمكن يساعدكم؟
Okay. So just to get back, Tamim is 8 months old boy who is known case of congenital heart disease, not on medication, and descended testis with craniosynostosis. We have been consulted for a whitish material which was observed during attempt to open the abdominal cavity by the neurosurgery team. He is a product of normal spontaneous vaginal delivery with uneventful pregnancy. He was discharged with his mother in a good clinical condition with a birth weight of 2.97. The mother mentioned that at age of 3 months, the patient started to have projectile non-bilious vomiting, which was diagnosed at that time to have gastroesophageal reflux disease, gastroesophageal reflux that will improve with time, and she was discharged home. At the age of 8 months, the patient was diagnosed to have craniosynostosis with increased intracranial pressure, for which he have been admitted in our hospital for managing of this hydrocephalus. Next. During the procedure, as we said, he had whitish material that have been suspected to have bowel injury. The pediatric surgery team have been involved, and they said there is no evidence of injury. So the operation was aborted, and the patient was kept on external ventricular device. Next. The patient was asymptomatic completely, apart from no weight gain since the age of 6 months. He has no history of abdominal pain, distension, diarrhea, or vomiting, no history of abdominal trauma, no history of jaundice or itching or change in urine color. He has no history of swelling, lower limb, facial, or sacral. He has no history of fever or decreased feeding or activity. The patient has no history of contact with sick people or recent travel or newcomers to hospital, to the house. There is no history of radiotherapy. His medical and surgical history, apart from what we mentioned, is negative. He has delayed vaccination since the age of 6 months. This is the area in which the mother was looking for the dysmorphic feature and these clinical details. He has gross developmental delay. His current age when we assessed this patient was 5 to 6 months. He was on regular feed formula, giving him 115 kilocalories per kg per day. There is no family history of similar disease, no family history of GI disease or malignancy, no family history of pancreatic disease. He is living in Riyadh with average socioeconomic status, and he is the first offspring of consanguineous marriage. So to conclude the history, 8 months old boy with congenital heart disease, with undescended testis and craniosynostosis, who have been found to have whitish material coming from the abdominal cavity during VB shunt insertion. Any question? Yeah, laparoscopic.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
That whitish material came through this one?
Through the abdominal cavity, the abdominal opening, through laparoscopic opening,
So
starting from the procedure.
Yeah,
Like fat or what?
It is whitish material. It's liquid-like. It's not fat. They said it is a liquid-like material, which was whitish.
Milky?
Milky, yes.
It's milky?
Yeah.
so they just opened the abdomen and found that he was asymptomatic completely. So it was incidental finding. Any question through the Zoom? Any further question? History examination?
Yes, bro. He was feeding regular formula, Q3 hours, with good sucking and taking almost 115 kilocalories per kg per day, as we calculated. There is no abdominal distension at all.
Any question from Zoom?
Assalamu alaikum.
Assalam.
Just a question, any history of steatorrhea, chronic diarrhea?
Nothing at all. He was passing soft stool. It was not steatorrhea, soft stool 2 times per day. He was completely asymptomatic, apart from no weight gain since the age of 6 months.
Okay, it's chylous, like chylous.
It is
aside.
milky material.
Thank you.
Any further questions?
If anybody have a question through Zoom, you can
have
block
question?
that question. This one. So we proceed to examination. Next slide. The patient on examination was looking well, active. He was even interactive with us. He was not jaundiced or in respiratory distress. He was not in pain. He was not connected to IV line or oxygen. He was there were no evidence. There were no rashes or evidence of a swelling, sacral or facial or lower limb. He was looking dysmorphic with abnormal head shape in form of plagiocephaly and trigonocephaly. He had low set ear and exophthalmos with hypertelorism, and he has parrot-beaked nose. Next slide. His weight was 6 kg, which is almost far away from the 3rd centile. His length was 70 cm at 50th centile, and his head circumference was 41 cm at 3rd centile. Next. His abdomen was not distended, with no obvious scars, apart from these laparoscopic scars. He has no hernia or masses. The abdomen, the umbilicus was everted and centralized. His abdominal girth was 36 cm. The abdomen was soft and lax with no palpable masses or organomegaly, and he has a negative shifting dullness. The other examination, apart from ejection systolic murmur through the cardiovascular, he is negative apart from this issue. Next. So, any question on exam? Sorry? No, we don't have it. Any questions through Zoom? Raise hand and ask question.
لو سمحتم اللي عنده أي سؤال ممكن يسأل through Zoom. Anyone having a question through Zoom, please, to ask. You can raise hand, please.
Dr. Muhammad, there is one question from Riham. You hear me?
I think no more question from Zoom.
So we continue. This like interaction from my colleague fellows. What's your differential diagnosis and how would you approach this patient? Anybody can have suggestions or differential diagnosis? You have a patient who is asymptomatic apart from this ventricular peritoneal shunt and dysmorphic feature, and no weight gain since the age of 6 months, and examination is completely normal apart from the dysmorphic feature, with the whitish material coming from the abdomen, milky material. What do you think? Yes.
When is that? Sweetheart.
Okay. Okay. Yes. Before, no. This is the first surgery which has been done to manage his intracranial pressure. Okay. Okay.
stool alpha-1 antitrypsin.
Could you please just repeat it quickly because of the Zoom baby?
So with this presence of failure to thrive, CNS craniosynostosis, dysmorphic features, with this chylous ascites to rule out lymphatic malformation, or primary lymphatic telangiectasia. So we will start with non-invasive way, CBC to look for lymphocyte count, and leukopenia, immunoglobulins, albumin level.
Correct.
For sure, routine as well investigation. Stool alpha-1 antitrypsin, if it's available. This is coming to my mind.
Plus analysis of fluid, the abdominal fluid which was collected by the surgery. Yes. Next slide. Sorry.
Also, question from Zoom: any change in the abdominal girth in the after the procedure or not?
No, we don't know because they did not measure the abdominal girth before the procedure.
Okay. So no more question, I think so, from Zoom. And you hear the question from the attendee.
Yeah, let's move to next slide. So our impression in this stage, this is most likely chylous ascites and most likely congenital cause based on what the patient presented with and based on his dysmorphic feature. Next slide. The fluid which was sent by the surgery came with cell count, unfortunately was sample clotted, but gram stain shows no organism. The albumin was 2.4 and glucose was 10. And at that time, the liver function test was normal and albumin was 3.4. And can anybody calculate the SAG for us? I mean, from my colleague. We have serum albumin of 3.4 and acetic albumin is 2.4. So it is 1. It is 1. So it is less than 1.1.
Serum 34 والالبومين from the fluid 24, so 34 minus 24
Yeah,
10,
so it is less
which
than
is
1.1. Next slide. Which makes the portal hypertensive causes less likely. Next slide. His CBC, as Dr. mentioned, it showed lymphopenia and hypochromic microcytic anemia. Next slide. CT abdomen was requested by the surgery team to rule out any perforation or any injury, and it showed left-sided retroperitoneal heterogeneous fluid with a multiple area of higher density tracking the psoas muscle. Next slide. Okay, next slide. So at this stage, our team was consulted, and we advised them to do a lymphogram, or if it's not available, any lymphatic study to assess the lymphatic state, and the tabbing to be repeated, looking for cell counts, CBC, WBC, and differentials, looking for glucose, triglyceride, and albumin, culture gram stain for fluid and acid fast bacilli, and to do abdominal ultrasound to assess the liver and the portal veins. Next slide. Interventional radiology interventional radiology was done, and it showed 15 ml of whitish material, milky whitish material. It shows no organism, no acid fast bacilli, but triglyceride was very high, which is going with chylous ascites. Next. So based on what we have from clinical history, from examination and calculation of SAG, normal liver function, we thought this whitish material is most likely congenital secondary to lymphatic abnormality. So I advised them to go for CT CAB to rule out any intra-abdominal or other pathologies, and lymphoscintigraphy or lymphography. Next. CT CAB was done. It showed the same area of fluid collection tracking the psoas muscle, otherwise unremarkable with no masses. Next. Lymphoscintigraphy. Can I have the next slide? Yeah. Lymphoscintigraphy at 20 minutes and at 2 hours. This is the posterior view. This is the anterior view. Shows abnormal tracer accumulation on the left side. This is the posterior view, the left side. At 20 minutes and at 2 hours. So it gives us, there is lymphatic abnormality. Next. So we started this patient on MCT-based formula, and we started this patient on octreotide. We were observing this patient for any possible side effect. We were measuring abdominal girth, and no complications have been observed on this patient through inpatient or even outpatient care. Next. And patient got discharged with similar dose, 2 micro per kg, and MCT formula, continued to be asymptomatic as he was. His abdominal girth was dropping from 36 to 34 cm, and it was measured by one physician. And his calorie intake was almost 100 kilocalories per kg per day. Next. We dropped octreotide to 1 mic per kg to look for the effect of octreotide. Is it helpful for this patient or no? And patient started to have abdominal girth 37. So we resume it to 2 mic per kg, and abdominal girth goes back to 34 cm. Next slide.
Just 1 second, Dr. Ali. So at this stage, we have patient with chylous ascites.
Yes.
With no known cause.
Yeah.
So the question for the audience, what they think, what's the cause for this abnormality? Why he has chylous ascites?
Yeah. Do you want me to answer this? Okay.
No, I want the audience.
Can anybody help us on this question? Why we thought this? We have a patient with chylous ascites who was responding to MCT-based formula and octreotide. Okay, so based on what we have from history, from examination, patient dysmorphic, he doesn't have any other history or examination, are all negative. We're thinking that this is most likely congenital cause of lymphatic abnormality. Next. So at this stage, during follow-up, his WIS came for a Noonan syndrome, which is PTPN11. So he was diagnosed with Noonan syndrome. That's what, then we concluded that this patient most likely has congenital lymphatic abnormality. As we know that Noonan syndrome, we will show it later on. It is associated with dysplasia, hypoplasia, or hyperplasia of lymphatics. Next slide. So we just start a brief review on chylous ascites as it was discussed in last meeting, last GI meeting. We just go brief this, then we will see the association between Noonan and chylous ascites. Next. As we know that, chylous ascites, sorry. Might be associated, it is accounting for 1 in 20,000 tertiary hospital admission. It might be caused by trauma or rupture of lymphatics or increased peritoneal lymphatic pressure secondary to obstruction. Next. It can be classified as portal or non-portal. The portal as well can be classified into hepatic, prehepatic, and post-hepatic. Next slide. Next slide. عندي okay, the etiological classification of chylous ascites, it is neoplastic or congenital, I mean diseased or neoplastic. The congenital, I pointed here on primary lymphatic hypoplasia and hyperplasia, and we will see later on the association. Next. The diagnostic approach consists of, next, suspecting the diagnosis of chylous ascites or chylous presentation, confirming the presence of the milky material or the chylous in the peritoneal cavity, and determining the underlying etiology. These are the main diagnostic approach for the chylous ascites. Evaluation, history, and examination, then assessment of chylous ascites is very important. Abdominal paracentesis is the most important in diagnosing chylous ascites, as it might present in this, like in this patient, milky or cloudy or turbid fluid. Next. As we can see here in this picture. We have in all cases to ask for gross examination, cell count, gram stain and culture, and concentration of glucose, total protein, albumin, amylase, lactate, and triglyceride level. And in some cases, acid fast bacilli and PCR might be observed if the TB is suspected. These are the characteristics for chylous ascites. Is triglyceride more than 200? In our patient, it was 5.1. Next. CT scan can be done to rule out intra-abdominal pathology or malignancies. Next. Lymphoscintigraphy or lymphangiography. Actually, lymphangiography is the golden standard for diagnosis of lymphatic abnormality. Lymphoscintigraphy carries a very positive point against the lymphangiography, as it is non-invasive and it carries no side effect or contraindication. Next. Next. The management part, next. The mainstay of treatment is conservative, as we know. That we have to decrease the chylous production, improving the nutrition with MCT-based formula, vitamin, fat-soluble vitamin supplementation, and some patients might need TBN. And treatment for underlying cause, of course. Octreotide might help in some cases. Paracentesis in patients who have respiratory distress or respiratory issue might help. Next. Next. There are some surgical solution for this chylous ascites. Next. In cases of severe cirrhosis who are presenting with ascites, not responding to conventional or conservative management, tips might help. Next. In this case, they have a patient who have chylous ascites, was presented with was not responding to conservative management. They did lymphogram, they identified the area, and they put fibrin glue surgically, and patient totally improved. Next. This is the area of chylous production. Next. And they put the fibrin glue, then patient improved totally. So this is our main talk, and will not take, inshallah, more than 3 minutes. Noonan syndrome and chylous ascites. As we know that Noonan syndrome, one of a craniofacial syndrome, it presents with many genes, PTPN11, KRAS, next. And it is associated with dysplasia, hypoplasia, or hyperplasia. Next, Tamara. Next. The genes that are involved in patient, it might present with like a PTPN11, more than 100 cases report. Noonan syndrome with SOS1, few cases with lymphedema. Noonan syndrome with craniofacial syndromes, also few cases with chylothorax. So the presentation is different based on different gene, and every gene might have different presentation. Next. In this study, they have 11 cases. Next. of Noonan syndrome with different gene, different age group from 37, 19-year-old, 26 years old, 11 years old, with different gene production, BTBN11, and different presentation. As we said, the chylus reflex or intestinal lymphangiectasia, in this case is bilateral chylothorax, other cases with intestinal lymphangiectasia. Next. These are the 11 cases with different age group and different gene, with different presentation. Next. Just I want to mention this study while searching for this topic. I have seen this patient who was improving on MEK inhibitor, multigene activating protein, which is trametinib. They have a patient, next slide. They have a patient who was X28 weaker, presented initially at age of 5 years and 2 months with chylothorax. It was drained surgically and patient got discharged. Then the patient again presented at age of 14 years with upper GI bleeding, protein lesion enteropathy, with chylothorax. So they investigated this patient thoroughly, found to have lymphangiectasia and chylothorax. They started this patient on conservative management, MCT and base, and started the octreotide. Patient did not improve. They started this patient trametinib. Next slide. Yes, as we can see here, this is the picture pre and post medication. It takes actually like 3 to 5 months, then the patient gets dramatically improved. In this picture, the pulmonary lymphangiectasia was changed dramatically. This is the pre and post medication. Next slide. Yeah, intestinal lymphangiectasia as well on trametinib improved pre and post. And this is the chylothorax improved pre and post. Next slide. His hemoglobin level improved dramatically after starting trametinib. His albumin as well improved within a few months after starting this medication. Next. So they concluded in this study, next. MEK inhibitor in patient with retinopathy with severe presentation might present with severe central lymphatic system disease. The treatment modality that has been potentially to improve the complication of genetic defect of KRAS pathway in patient with severe retinopathic with severe lymphatic dysfunction. This medication should be potentially considered. Next. So this is the end. Take-home message: chylus ascites. Diagnosis consists of suspecting diagnosis, confirming the diagnosis, and looking for the underlying pathology. And the treatment always conservative with MCT-based formula, and sometimes octreotide might help. And always link your case, history, and examination together. As in our case, we were looking for others, yes, but we have a patient with history, dysmorphic feature, so we collected the whole case, and we came, this is most likely congenital cause. And thank you.
Thank you very much, Dr. Ali. Very well done. My question to my colleague, my senior colleague, did you see such case before, Noonan syndrome with chylus ascites? Anybody face? No. Would you treat chylus ascites if it's asymptomatic? Because this patient, his abdominal girth is the only thing, and even the abdominal girth increase was soft, lax, nothing, it just decreased the abdominal girth, but it wasn't bothering him. Would you treat such case? Should we treat him? Should we stop?
Thank you very much, Dr. Ali, for this excellent presentation. And I was going to ask this question: if the patient is asymptomatic, maybe I think I will put him in MCT oil-based formula. However, octreotide, you have no markers to monitor the response. And the albumin عنده normal. I'm not sure whether you monitored his lymphocyte count.
It was improving in last visits.
This is one. You have nothing to monitor except albumin and lymphocyte count, and the abdominal girth. It may be gas. And when you measure it at the time of measurement, so it's very difficult, to judge. And I will just use MCT oil based and wait. The only thing which warrants, treatment with octreotide is the growth.
Yeah, and he started to.
If he's, his weight is improving and he's getting benefit from this medication, I will use it. However, if not, then maybe dietary intervention is enough.
And Dr. Ali, this patient, we have seen him in last visit. His weight was far away from third centile. He started to track the third centile. He's improving from weight point of view.
This is good. This is one marker to monitor, response to treatment.
Yeah. So, thank you.
Thank you, Dr. Ali. يعطيك العافية. So now we will hear from Dr. Abdul Aziz, another interesting case. So go ahead. Hopefully this time the individual will not fail us.
Assalamu alaikum. My name is Dr. Abdul Aziz Damkh, Pediatric GI Fellow. With me in this case, Dr. Aman Al-Asmi, the Pediatric GI Consultant. We are representing King Saud University Medical City. I'm honored to be presenter at this meeting. Next slide. So our case, 4 weeks old term baby, present to our ER with jaundice, non-projectile and bilious vomiting associated with distended abdomen for 2 weeks. There was no history of bile stool, diarrhea or constipation, fever or lethargy or abnormal movement, no history of diarrhea or constipation, no history of runny nose or cough, contact with a sick patient. Also, there was no history of skin rashes or epistaxis or bruises. His term baby, birth weight 2.7 kg, delivered by venous delivery, admitted in Wadi Dawasir hospital in an ICU as birth asphyxia with hyperbilirubinemia. He required oxygen support, bucket RBC, phototherapy, and discharge after 12 days. Unfortunately, his jaundice worsening over 1 week with persist vomiting, readmission in Armed Forces Hospital in Wadi Dawasir on 4th week of life, and signed them and present to our ER. There is a query history of oligohydramnios, but there was no report about that. Nutritional history, he's on regular formula feeding. There was no herbal medication has been given. Family history, parents are second-degree relative. He's a first child. There was history of male cousin died of cardiopulmonary arrest and liver failure at age of 2 months old with unknown diagnosis. Also, there is one female cousin diagnosed as a case of PFIC type 2, diagnosed at age of 5 months. So initial assessment in our ER, patient was looks pale, jaundiced, dehydrated, afebrile, saturating well in room air. The abdomen at that time was distended, hepatomegaly, liver span was almost 7 centimeters. There was present bowel sound with bilateral inguinal hernia were reducible. Other exams were unremarkable, and basic labs workup were done at that time. Blood gas showed metabolic acidosis with pH 7.1 and bicarb 14. Initial CBC showed normocytic normochromic anemia with normal inflammatory markers. His initial UNE glucose was 3, showing hypoglycemia, hypokalemia, and lactic acid was 16. His initial LFTs showed direct hyperbilirubinemia with normal gamma GT, mildly elevated transaminase. Albumin at that time was 24, LINR 2.4, with BT of 32. So, with this presentation, what is your differential diagnosis?
لو سمحتم اللي اي واحد عنده استفسار من الزوم ممكن يرفع يده لاجل ناخذ الاسئله والسؤال يكون واضح للجميع حتى حضوريا يكون واضح.
So we have patient who presented with acute liver failure. He has significant family history of liver disease, of PFIC type 2. he presented with almost compensating liver failure, INR prolonged, albumin low. His initial CBC showed low red blood cell and low hemoglobin. So what do you think? Anybody? لا تحطها علي. Anybody? Yeah, fellows. Such case if it's come to the ER and you are the one who dealing with it. السؤال للfellows.
To make it more easy, direct hyperbilirubinemia with normal gamma GT.
Dr. Nawaf, if you face such case, what do you think of? What's your differential? What's your approach?
At this age, I have to rule out neonatal sepsis. Infection is common at this age with this presentation. And also, we have, there is metabolic acidosis and dehydrate. We have to rule out any metabolic disease at this age also.
Especially in our community.
Yes.
Is number one.
Because of the...
Sometimes they will present with liver failure. Thank you. Go ahead, Dr. Abdelaziz.
So our differential based on direct hyperbilirubinemia with normal gamma GT. First of our differential was gestational autoimmune liver disease. We think also of metabolic disease like tyrosinemia, galactosemia. Also, we think of endocrinopathies like hypoparathyroidism or hypothyroidism, HLH. With the history of PIFIC, we put in our differential PIFIC type 1 or 2, and bile acid synthesis defect. So when we saw the patient, we
Dr.
request...
Abdelaziz, Dr. Ali has a question.
Now, one of the important differential is mitochondrial disease because this patient has hypoglycemia and has high lactic acidosis.
Sure.
So I think I will put this high in my differential diagnosis. With the other differential, HLH.
He had one episode of hypoglycemia. Even in Wadi Dwasir, he wasn't hypoglycemic at that time. Only in our ER.
بس ذكرتها خلاص.
Sure.
It's very valid point.
Next. لا. Okay. Just for there. So we request we want to screen for our differential diagnosis. So thyroid function test was done, which came normal. Urine analysis to rule out UTI came normal. We asked for herpes simplex viruses, EBV, CMV, and also we asked for alpha fetoprotein, which came 15,225 with high ferritin 1,613, low fibrinogen, and no triglyceride. LDH was high, 344. We asked for urine for bile acid and succinyl acetone, all sent out. Abdominal ultrasound was done, showed mild hepatosplenomegaly with severe ascites. We also asked for MRI, looking for extra hepatic iron deposition, and we start the patient on vitamin K once daily. Also, this patient was seen by different teams, seen by our colleague in metabolic team. Their impression, less likely to be primary liver disease, more likely to be primary liver disease, unlikely to be metabolic. And they asked for urine organic acid, which was unremarkable, urine reducing substance, which came negative, and the plasma amino acid, it was sent out. Metabolic screening showed only high methionine level, and echo was normal. They recommend to start tyrosine free and lactose free formula, and they ask for FLASH-OS. Surprisingly, FLASH-OS revealed homozygous variant of SL C5A1, which suggests glucose-galactose malabsorption. At this stage, this cannot explain the whole picture, but can explain one episode of hypoglycemia and metabolic acidosis, but it will not explain the whole picture. So we start him in galactomine 19, and we continue our workup. So after 5 days, patient is still sick, and he get even more sicker, worsening ascites, and has one episode of hypothermia. So CBC at that time showed pancytopenia with ANCA with the absolute neutrophil count 0.9. Blood and urine and tracheal aspirate were taken with this one episode of hypothermia and showed Pseudomonas aeruginosa. Herpes simplex virus and EBV PCR came to be negative. CMV PCR came positive. LFT still showed direct hyperbilirubinemia with normal gamma GT, mildly elevated transaminase, and coagulation profile getting worse. INR 3.4, BT 45, with D-dimer 3.5. So ID team were consulted at that time, and their impression sepsis plus CMV-induced HLH. Patient was started in antibiotic, antifungal, and antiviral. Hemato-oncology team were consulted. Their impression HLH either primary or secondary. They request peripheral blood smear, which came not conclusive. They asked for bone marrow aspiration and biopsy. Bone marrow showed no evidence of leukemia or lymphoma. There is occasional histiocyte with a rare hemophagocytic activity. So this bone marrow result, when we discussed with our hematologist, they said it's not classical presentation of HLH, but we cannot rule it out also. So it's like gray area. Rheumatology team saw the patient and their impression also HLH versus primary immunodeficiency, and they recommend to start treatment of secondary HLH, IVIG, steroid, anakinra. We also consult immunology team to rule out primary immunodeficiency, and his baseline immunoglobulin level and lymphocyte count were normal, and the immunology team, they rule out primary immunodeficiency. Week later, patient is still sick, worsening ascites. Our impression at that time, HLH versus gall. We request for acetic tap and analysis. MRI result came out, showed hepatosplenomegaly, hepatic iron concentration between 2.2 and 2.5, which is mildly elevated and significant. Adrenal gland, there was mild iron overload, and pancreas showed sign of iron overload. 8 days of admission, patient becomes sicker. He need to be intubated because of severe ascites, which is compromised respiratory status due to high intra-abdominal pressure. Paracentesis done ultrasound guided under aseptic technique and connected to free drain. Patient at that time was on vitamin K, factor 7, FFP, antifungal, antibacterial, antiviral, with treatment of secondary HLH. 2 weeks later, patient is still not improved. He developed capiground vomiting, melena, and blood in urine, worsening ascites drain with streaks of blood. INR at that time, 7.2, and with BT of 88. Here, total bilirubin decreased to 39 and with direct 22. So our plan to change the PBI from IV to continuous infusion, and buccal biopsy was done by maxillofacial team, which shows negative results. So at this stage, we exclude gall. 4 weeks later, patient condition worsening, required inotropes plus mechanical ventilator support. He was on HLH protocol, and the previous medication mentioned earlier. His coagulation profile is still high, but at this stage, bilirubin start to be high again, total 267 with direct of 174. ALT, AST also become higher more than before. So our risk result came out. It showed homozygous mutation in NLRC4 gene, which is cause syndrome of prenatal autoinflammation with HLH, hepatosplenomegaly, fetal thrombotic vasculopathy, and congenital anemia and ascites. It is autosomal recessive, and parents are both heterozygous for NLRC4 variant. 5 weeks later, patient was unstable with inotropes plus mechanical ventilator support and has multiple desatting and bradycardia. He shifted to high frequency with maximum inotropes. Needed CPR was needed, and patient expired with and family was informed at that time.
Okay. So at this stage, we have this patient who has flash WIS, then WIS. He has, again, family history of PIFIC, family history of liver disease. His flash showed glucose galactose malabsorption, which doesn't go with the clinical picture. Then it came with that syndrome. We discussed it with the genetics. They said this is variant, so it's not significant. However, all the manifestation of that syndrome goes with our patient. Can we ignore that? After that, we discuss again, if it's the syndrome, what can we offer him? It's the same treatment, and the prognosis known to be very bad.
Yes.
So there was no hope for him, unfortunately. So Dr. Abdulaziz will talk about this syndrome. I was against the genetics. I'm not genetics, but for me, all the criteria fit our patient except one. So we cannot ignore it, especially with that significant family history. And also he will tell us more maybe about WIS,
yes,
till which degree we can trust and depend on WIS. Go ahead, Dr. Abdulaziz.
So this case published in 2017 about novel NLRC4 mutation, which causes syndrome of prenatal autoinflammation with HLH, hepatosplenomegaly, fetal thrombotic vasculopathy, and congenital anemia and ascites. Next slide, please. So autoinflammatory disease are caused by pathological activation of innate immune system. Primary HLH is aggressive syndrome of excessive immune activation and caused by immunogenic mutation resulting in cytotoxic cell defect with subsequent failure to eliminate activated macrophages. Secondary HLH is often diagnosed as a case without known Mendelian inheritance. However, some cases, secondary HLH have been shown to harbor mutation with a partial dysfunction of cytotoxic system. Recently, macrophages intrinsic abnormality caused by NLRC4 inflammation mutation have been linked to autoinflammation and recurrent macrophages activation syndrome, resembling a primary HLH. So in this report, 28-week preterm infant with congenital anemia and ascites have heavy edematous placenta, fetal thrombotic vasculopathy, who developed hepatosplenomegaly and explained systemic inflammation with laboratory features of HLH and early postnatal course, and he was died at 2 months of age. Next slide. So there was also in this case, and this is a difference between our case and the case published here. There was extensive acute and chronic ischemic bowel disease with mated bowel loops, fibrous adhesions, and patchy necrotizing enterocolitis features. WIS analysis demonstrate a novel mosaic heterozygous NLRC4 de novo mutation predicted to cause a dominant gain of function mutation resulting in an active protein. The assembly of NLRC4 inflammation via an induced self-propagation mechanism likely enable a constant process of systemic macrophages activation presumed to be initiated in utero in this patient. So in this table, this is the criteria for diagnosis of HLH. In the case published here, they get 5 out of 8. In our case, we get 4. Splenomegaly, cytopenia, fibrinogen was low, and high ferritin. Considering that we did not include the result of bone marrow result, which showed histocyte and hemophagocytic activity. Next slide. In this part, I will speak about reanalysis of WIS. So in this study published in, this article was published in 2019 in Genome of Medicine journal about reanalysis about reanalysis of WIS data uncovers an overdiagnostic variant and improve molecular diagnostic yields for sudden death and idiopathic disease. So they did 101 WIS cases, 51 was rare idiopathic disease, and 50 was cases of early sudden unexplained death. Next slide. Initial analysis revealed diagnostic variant in 25% of rare disease and 10% of sudden death cases. When they did reanalysis again, identification of additional diagnostic variant in was 5.9 in a rare disease cases and 2 in sudden unexplained death, which is increased their molecular diagnostic yield to 31 in rare disease from 25 and to 12 from 10 in sudden death. So they conclude this finding highlight the potential of reanalysis to reveal diagnostic variant in cases that remain undiagnosed after initial WIS. And thank you.
شكرا جزيلا دكتور عبد العزيز يعطيك العافية.
الله يعافيك.
طيب, by this we conclude our last case. Any comments? طيب, thank you very much the audience in this room and for the audience in the Zoom. Thank you, Dr. Tamran.
Thank you for the presenting hospital case UMC for this interesting topics and the reviews and lectures, and for the speakers, for Dr. Mona for moderating the, this great presentations and great moderation. And I don't know if you have any further comments, Dr. Mona?
No, thank you very much.
We want to thank you all. Thank you all Zoom and also who is physically attended. Thank you all.